Hello, and welcome to our 9th annual NYIT EDS Hypermobility Patient and Provider Symposium. I'm Dr. Bernadette Riley, and I'm honored to moderate and be part of this symposium. It's our 9th year doing it. This year we added a bunch of students and our research, so we're excited to get this started. Our objective today, the first thing we want to showcase is all we've done at the NYIT EDS Hypermobility Center. One of the things we want to go through, as you'll see throughout the day, is I wanted to show you our students who are working on such wonderful research projects. I wanted to show you our faculty, including Dr. Cohen and Dr. Noto, who will show us all that they're doing in not only in the center, but also with their research. So we're going to start with what we're doing here and showcase that. The first thing we did in 2025 was we were able to become a Center of Network Excellence with the EDS Society. We're so thankful that they accepted our second application, and we're so honored to be part of it. We hosted Professor Lara Bloom on January 29th, 2026 at our Brick Center, which is one of our newest centers here at NYIT Old Westbury. And we were so wonderful to have the core network visit, and we're so happy to be part of this wonderful group of people. One thing that we've been doing a lot at the EDS Center is focusing on nutrition. As you'll see later on in the symposium, our students have done a research paper and have presented many times on the topic of nutrition. Specifically, we've been thinking of things like the ketogenic diet, anti-inflammatory diet, and we look for things not only with regards to underweight, but also for obesity. So we've been really focusing on nutrition. In 2025, we received the ACOM Food as Medicine grant. We worked with our partner of the ACOFP in order to incorporate a hands-on culinary medicine workshop. We wanted to improve osteopathic medical students and other healthcare providers their access to affordable and understanding the integration of nutrition. And we were so happy to be part of this wonderful grant, which took place in California, April 2025. It went really well. We're still working on the research with it, and we'll be presenting it really soon. And we're just thankful to be part of that. And of course, we take into consideration, especially with regards to hypermobility, all the specific nutritional components that can come with that. So things we see in our patients are multiple food allergies, ARFID. A lot of our patients are gluten-free. There are multiple health conditions. And of course, we look at the chronic pain associated with patients who are hypermobile or who have EDS. And we wonder if there's any treatment options that we can add in their nutrition. And things that we recognize are barriers that our patients can face, such as barriers to refrigeration, limited or a lot of salt content, electrolytes, and then of course we're thinking about access to fresh and healthy food, mostly those that are fresh vegetables, fresh fruits, and so we take that into consideration. We're doing research on it, and we're hoping to find ways to help our patients with it. We try to incorporate lifestyle medicine, which has 6 pillars. One of their major pillars are nutrition. So the importance of a nutritious diet. There's also physical activity, which our patients sometimes have trouble with doing, but with the help of PT, OT, physiatry, Dr. Noto's prescriptions, we're hoping that they can get some sort of physical activity in their life. Sleep is so important. As you'll see, we had a research paper to show the sleep effects that EDS and hypermobile patients can have. Stress less, that's always something that I find hard, but finding ways that you can lower your stress can help with lifestyle. And also the importance of social connection. That's why I always hold the symposium every year. That's why I always try to encourage, some kind of connection, whether it be on the internet, online, or in person, and the importance that we see of being connected, whether it's your network, from your faith, from your friends, or whatever way you can so that you're not isolated. And one of the other things is avoiding risky substances. And this could be your own risky substance. Some people, it's alcohol, some it's tobacco, some it's marijuana. Other times it could be things that you know you could go down a rabbit hole. For example, if your risky behavior could be something like social media and just watching hours, sometimes I could binge on things. So I try to avoid that as much as I can. We took this year and said, we really want to do some research on mental health and patients with EDS and hypermobility spectrum disorder. We've had a couple publications. We've had 2 more posters that are in the process, but we've studied the relationship between bipolar and obesity and EDS, and we recognize that things to look for and stuff like that could also be medications, obesogenic things, and so these are things we're thinking of. Another thing we did was a research project on the neuropsychological function and relationships in patients with EDS. So we recognize the brain fog, cognitive components, and other symptoms that can be seen as co-occurring conditions. And we're trying to do research to understand what those connections are about, why this happens, and what's the next step. Sleep. As I said before, one of the pillars of lifestyle medicine is the importance of sleep. So we looked into the sleep characteristics in individuals with EDS. We had a paper published. We worked with other institutions, wonderful people, which I thank so much. And we really saw that sleep disorders are really increased in prevalence in patients with EDS and hypermobility spectrum. Why is that? How can we help? We try to do an individualized treatment plan to understand your specific sleep problem and to try to deal with it, because we also recognize the importance of getting restorative sleep. I also am a professor. I'm a professor of family medicine here at NYIT COM. So I take with me all the knowledge. I run the EDS 4th year elective. I have students who follow me to see our wonderful patients. I teach when I go out. I lecture nationally on the subject of hypermobility and EDS. So I'm happy to say that throughout the country, we are really educating patients and providers as well as healthcare professionals on EDS. So I think it is increasing in prevalence, but I also think it's also increasing in the education surrounding it. And we do this because a lot of my patients come to me and they say, I got PTSD from doctors because they don't know what I'm going through. So I can honestly say, especially at NYIT COM and our osteopathic medical students, they know what Ehlers-Danlos syndrome is and they are looking for it and at it. Pain in the GI system. You'll see later on by our wonderful students that we are also looking at GI, pain, mouths, and this whole neuro-gut connection. So here are some papers that we did do with our colleagues at Campbell University. Thank you to them. We're really trying to go out the country to get like-minded individuals, healthcare providers who also have an interest in seeing patients who are hypermobile and EDS, so that our patients could be serviced throughout every state in the United States. We really have connections. I just came back from a conference that I was chairing, and we had an OMT session where it was OMT and the hypermobile patient. I can't tell you how many people were standing up asking questions about their patients. You know, these were all DOs, and it seems like, to me, the EDS is becoming more aware and providers want more education on it. So our goal is to get as much research published out there and access throughout the country so that people can read these articles. Fundraising, that's always important, especially here at NYIT. We were so grateful and blessed to have private donors, and with that, I'll show you what we were doing with it. We've also received some grants, and we increase our awareness for EDS. The in-house grants, because of our private donor, we were able to, in 2025, I was able to give out 2 winners for our in-house grant $10,000 each, and this was investigation of green light exposure on pain and severity and quality of life in individuals with hypermobile EDS. That PI was Dr. Noto. Congratulations on that study. It's still going on. Our second one was co-investigator in the 2025 comparative cardiovascular and autonomic profiling of EDS and hypermobility using an expanded EMR-based database in the cardiology clinic here. That's run by Dr. Cohen. He was the PI in those grants. And I misspoke, I'm sorry. Both of them, they received $7,500 for their 1-year grant each. And then in 2026, I'm happy to say that we wrote up a call for grant proposals. We opened it to the CHSLI system as well as the other colleges on our campus. And we were lucky enough to get 9 wonderful proposals, 3 of which we've asked them to submit their full IRB. So that's coming up. That's in 2026. This is for 1 grant of $20K due to our generous donor. And we look forward to seeing next year. I'll tell you which one we picked and we can look into that research. But I am just so amazed that we got such wonderful proposals. And just to show you, these are high quality cases. These are high quality grant applications with very high quality, high known individuals. And this is just going to show you that the EDS world is becoming big. Of course, under the wonderful work of Dr. Cohen and his great students, we've had multiple publications. Our newest one is in the invasive cardiology, the prevalence of cardiac symptoms in EDS and hypermobility spectrum disorder. We've had a couple posters at OMED, that's AOA, that's a big conference through the AOA. We had one about the utility of implantable loop recorders, that was done in 2025, but we're always trying to get posters out there, publications in high yield, high impact journals. Coming soon, some things that are out on posters and hopefully some publications soon are surrounding POTS, psychoactive drugs and their effect in the cardiac system, also their effect on nutrition, Barty DX monitors that Dr. Cohen utilizes a lot in his clinic, and dermatologic symptoms. We have a lot of students who are interested in dermatology, so we have some papers and hopefully posters and abstracts that are coming up. I have an interest in health advocacy, and with that, I have certain positions, like as Vice President of the Nassau County Medical Society and MISNI. I'm Assistant Secretary for MISNI. With it, whenever I meet members of Congress or members of the House of Representatives, I always speak about my work with EDS. You'd be shocked how many people have a connection to it in some ways. People do know about it, but I take with me my advocacy for patients with chronic pain and for patients with co-occurring conditions in all that I do. So I am thinking of you. And I just want to say a big thank you, not only to all of our patients, but to NYIT. I thank so much the leadership for letting this all happen. I thank all that so many people who have done everything for us, like the EDS committee. I thank everyone at the Academic Healthcare Center. I thank Terry Miarino, the EDS PA. I thank Gail Muller, the EDS coordinator. I thank my chair, Dr. Shefflin. I thank everyone who's helped me to make this center as big as it is now. And I thank anyone that I'm forgetting, just know that I'm truly grateful and have gratitude towards you. So now we're going to hear our rest of our speakers, and I look forward to seeing you at our 10th. Since last year, we have decided to highlight our students, and I am so honored to have 2 of the best students with me who have been with me, working with me, passionate about Ehlers-Danlos syndrome care since their first year. Both of them came up to me during their first year, during a time of their osteopathic medical school, that they were concentrating on their schoolwork, and told me that they have a passion not only in taking care of patients with complex medical conditions, but specifically for the hypermobile EDS patient.
It is such an honor to work with them. Now they're third-year medical students out on rotations. They've taken their time rotating with me through the clinic and volunteered their time in multiple research projects that we've seen. So it's such an honor for me to highlight, especially my two wonderful students who are right beside me. Our first one I want to highlight is Annette. Annette Pietaru is a third-year osteopathic medical student from Glen Cove, New York. She received her BS degree at New York Tech. She actually did the BSDO program, in which she became a DO in 7 years, as well as getting her bachelor's degree. She plans to specialize in OBGYN and is interested in maternal fetal medicine. She's from a family of OBs and has a mentor in her mother who also takes care of complex OBGYN patients. Her interest in EDS research comes from all of her clinical experiences, and she recognizes the significant diagnostic delays, multi-system burdens, and gaps in healthcare faced by EDS patients. Outside of medicine, she also plays with her dog, has a wonderful family, all of which are going into medicine, except for her dad, who is a big supporter of medicine. And we're just so happy to have you, Annette. It's been a pleasure working with you from day one. Next is Emma Rivalese. So Emma has a passion for EDS. Since day one, she has committed her care and her medical education to the advancement of osteopathic research. She has become a fellow with the EDS Society's ECHO, which is a competitive program to which she was picked out of many medical students. She is from Shelton, Connecticut. She received her Bachelor's of Science in Biology at Brandeis University. She plans to specialize in pediatrics, but due to her love of EDS, she's thinking of a specialty in rheumatology. Her interest in EDS comes from her mother, who is an amazing woman who was diagnosed with a vascular subtype of EDS, able to have Emma, raise Emma into the wonderful woman that she's become. And she's witnessed her experience not only with her own, but also her mother's chronic pain. So that made her passionate about EDS care. She's volunteered with the EDS Canada Foundation and is a member of the EDS Society's healthcare student. Outside of medicine, Emma loves to play with her kitty. She also won the New York Tech Alumni Scholarship in 2025, which I was honored to give her as well. And we're so proud to have Emma on our team. As you can see, the medical students really at New York Tech, we let them not only teach them about EDS and other complex disorders, but we also have them recognize patients with complex disabilities and how hard it is to get medical care. So we're going to now focus on their research and show you what we're doing here with regards to EDS at New York Tech.
Here are the 3 studies that we've looked at over the past few years that we're going to be talking about today. First, before we get started, I'm just going to go over some of the basic symptoms and comorbidities of EDS, specifically HEDS, the hypermobility type. This includes joint hypermobility and dislocations, skin hyperextensibility, easy scarring, easy bruising, migraines, fatigue, anxiety, depression, multiple GI complications, along with chronic pain.
So the first project that we're going to be talking about is the ketogenic diet and its applications in EDS. And so we recently published this paper in the Osteopathic Family Physician Journal. And so our study aim was to look at the considerations and potential benefits of using the ketogenic diet, or KD, as part of management in EDS. And what we found was that the ketogenic diet has potential to improve EDS symptoms through its anti-inflammatory effects, improvement of cardiovascular function, energy improvement, and overall neurological benefits. And so, along with proper vitamin supplementation, the ketogenic diet has potential to become part of comprehensive management of our EDS patients. And so this is a figure that we created to show how there are inherent genetic mutations in collagen, along with nutritional deficiencies that impair collagen synthesis, cross-linking, and overall stability. And so in EDS, we have genetic mutations such as COL3A1 that impair the formation of proper collagen, along with nutritional deficiencies in copper, zinc, and vitamin C. And again, these impair overall collagen stability. And these cause our EDS presentations and our direct and indirect symptoms, such as joint hypermobility, skin hyperelasticity, poor wound healing, blood vessel fragility, and fatigue, memory, attention problems, and also other comorbid conditions such as GI dysmotility, nausea, IBS, reflux, and dysautonomia. And this is another figure that created showing the potential mechanism for how the ketogenic diet can help with EDS. And so the ketogenic diet itself causes reduced blood glucose levels and reduced insulin secretion. And so overall, we have an increased production of ketone bodies and glucagon release. And this causes reduced oxidative stress in the body through reduction of NLRP3 inflammasome complex and reduced pro-inflammatory cytokines. Also, increased dietary lipids and protein stimulates the release of CCK, which enhances vagal afferent pathways. And so overall, we have an increased parasympathetic response that will reduce inflammation in the body.
The next project that I'm going to be talking about is the median arcuate ligament syndrome, a case report and literature review on the challenges of diagnosis. So this study aimed to discuss a patient in a case report with median arcuate ligament syndrome, or MALS, and comorbid EDS and postural orthostatic tachycardia syndrome, or POTS. All three of these syndromes have significant diagnostic challenges, and earlier recognition of HEDS we concluded might help prompt identification of vascular compression syndrome such as MALS. Therefore, there needs to be greater awareness among radiologists and gastroenterologists, as well as increased targeted evaluation of celiac artery blood flow to reduce diagnostic delays of MALS. Here is a comparison between normal anatomy and anatomy in MALS syndrome. And so in MALS, the median arcuate ligament compresses the celiac artery as it branches off the aorta. So when you eat food and there's increased blood flow through the celiac artery, there's going to be compression and less blood flow in MALS patients. As you can see here, these are two different CT scans. On the left is normal anatomy of blood flowing from the aorta into the celiac artery. And on the right is a MALS patient, same CT scan. However, you see that there is some stenosis from the median arcuate ligament compressing the celiac artery as it branches from the aorta. This compression causes postprandial pain as well as delayed gastric emptying, bloating, diarrhea, constipation, nausea, vomiting, which results in weight loss, as well as epigastric pain, fatigue, and exercise intolerance in MALS patients. This is a diagram and timeline of our patient starting from month 0 with onset of abdominal pain, following along her diagnosis pathway. So she started about 2 years in of having pain. She got a GI workup that included colonoscopy, endoscopy, CT, MRI. She was diagnosed at that time with IBS and POTS, as well, followed by adrenal dysfunction. She was then diagnosed with HEDS and diagnosed with MALS. After that, she received a celiac nerve block, plexus block, with alleviation of symptoms that caused her surgeon to believe that her symptoms could be relieved with MALS open surgery, in which he resected the median arcuate ligament as well as some of the celiac plexus ganglions. And 6 months following surgery, to this day, she is currently free from MALS symptoms.
So the last paper we want to talk about is EDS in women's health and special considerations for reproductive care. So the study aim was to summarize evidence on the gynecologic, fertility, pregnancy, and postpartum management in women with EDS. And so what we found was that women with EDS experienced significantly higher rates of menstrual dysfunctions, infertility, pregnancy complications, and postpartum morbidity. We found that vascular type EDS has a very high maternal risk, while hypermobile EDS, the more common subtype, is also associated with significant obstetric and pelvic floor complications. We concluded that EDS presents with complex reproductive healthcare challenges that require early diagnosis, recognition of the different subtypes of EDS to guide management, and overall, more research is needed to establish standardized clinical guidelines for labor and delivery and postpartum management.
And as you can see here at New York Tech, we recognize the importance of evidence-based research, especially in fields such as EDS, which require a coordinated care across multiple specialties in order to give our patients the best individualized treatment plan.
Today on our EDS Symposium, we're going to highlight two wonderful students' research and also highlight the research done at NYIT's EDS Center. Today we're going to talk about EDS and the hematologic and spinal abnormalities that are associated with all the different types. I'm lucky and honored to have our two students here today, both of which I've been introduced through Dr. Todd Cohen, who we're going to see later on in the symposium, and I've just had the honor of working with them over the past 2+ years, and it's been such a joy. So I can't wait to introduce you to them. The first one is Dimitra Menakakis. I'm so proud of her. She's a 4th-year star here at NYIT Com. She's been working not only in cardiology research, but also at the EDS Center, donates her time seeing patients, volunteers, did the 4th-year EDS elective and many months electives on the cardiology elective with Dr. Todd Cohen, has conducted much cardiac research and EDS research, especially in this one, which we'll see, with regards to HEDS and spinal abnormalities. And she's just been a star. I'm looking so forward to see her going on to her internal medicine residency, where she'll match in just another few months, and also on to her fellowship, which we hope is in cardiology. The next one is Bilal. Bilal's been with me for the past 2 years. Bilal Nazi. He's a 2nd-year NYIT Com student. He's been working closely with Dr. Cohen, including being included into his very competitive summer research program. He then went and met with me so we could combine our studies, and we have done a lot of cardiac research. Bilal is interested specifically in hematology, and he came up with some of these ideas, which has been just a pleasure to working with, and really we've also spoken to other hematologists, and it's been a great journey together. He not only conducts research in the cardiac center, but also at the EDS Center, and he's collaborated extensively on a lot of projects, including Dr. Todd Cohen's newest HOT Center. And we just can't wait to hear, so we're looking forward to listening to their research.
Thank you so much, Dr. Riley, for having me today. The name of the project that I'll be discussing today is the impact of spinal abnormalities on cardiac dysautonomia prevalence in patients with hypermobile EDS, also known as HEDS. So a little bit about the background of the project. HEDS is frequently associated with autonomic dysfunction. And what I realized in the clinic was that some patients had spinal abnormalities, but their contribution to cardiac dysautonomia remains poorly understood. So my hypothesis was that mechanical compression from these spinal abnormalities may affect their autonomic function. So the objective of the study was to investigate whether spine-related abnormalities in HEDS correlate with higher rates of cardiac dysautonomia. So a little bit about the methods. It was a retrospective study that analyzed patients from the Long Island Heart Rhythm Center with both confirmed HEDS and spinal abnormalities. So now I'll be talking about the spinal abnormalities that I saw in these patients, and the corresponding pictures are on the right-hand side. So for Chiari malformation, and this is type 1, you can see it in the upper right-hand corner, circled in yellow. This is where you have the cerebellum, which is the bottom portion of the brain that extends downward into the foramen magnum, which is just a fancy word for the base of the skull where the spinal cord goes through. Then we have tethered cord, which is seen in that middle picture on the right-hand side, and the yellow arrow is pointing to it. And this is where the spinal cord is abnormally attached to tissues in the spine. And then lastly, we have craniocervical instability, also known as CCI, and this is seen in the bottom right-hand picture. This is where you have weak ligaments causing excessive movement, and you can see this specifically within the cervical region. So now a little bit more about the dysautonomia diagnoses. POTS was the most common, which stands for postural orthostatic tachycardia syndrome. We also had neurocardiogenic syncope, orthostatic hypotension, autonomic neuropathy, and generalized dysautonomia. For the control group, they were matched by age, sex, and HEDS diagnosis. Then in order to find the associations between spinal abnormalities and dysautonomia, we ran a bunch of stats tests, and statistical significance was set at a p-value less than or equal to 0.05. So a little bit more about the results. The study cohort included a total of 113 HEDS patients. Out of these patients, 23 had spinal abnormalities, which was about 20.4%, while 90 did not, which was the majority at 76.6%. The most prevalent type of spinal abnormality was Chiari malformation, and 11 patients had this. 10 patients had craniocervical instability, and 5 had tethered cord syndrome, which was the least prevalent. Now we can direct our attention to the right-hand side where there's a bar graph. On the x-axis, it's types of dysautonomia, and on the y-axis, this represents the percentage of HEDS patients that have this type of dysautonomia. So in the lighter blue, you can see that this represents the group that has spinal abnormalities, and in the darker navy blue, this is the control group that has no spinal abnormalities. So in the group with the spinal abnormalities, 17 had dysautonomia, which was 73.9%, and POTS was the most common, as you can see on that bar graph, with 13 patients having this. For neurocardiogenic syncope, 2 patients had this. For orthostatic hypotension, 2 patients had this. 1 patient had autonomic neuropathy, and 1 patient had generalized dysautonomia. Now moving over to the control group, again, it's that darker navy blue on the bar graph. You can see that a total of 10 patients had dysautonomia, which was 43.5%. 7 patients total had POTS, 2 patients had neurocardiogenic syncope, and 1 patient had generalized dysautonomia. After we ran the stats, the p-value was equal to 0.036, which was considered to be statistically significant. So for the conclusions of the study, there was a statistically significant association between spinal abnormalities and increased prevalence of cardiac dysautonomia among patients with HEDS. Something we have to keep in mind is that dysautonomia really impacts the quality of a patient's life. So it's important to realize that if you do have a patient with HEDS and spinal abnormalities, they may require earlier tilt table testing to evaluate for any type of dysautonomia. It's always important to make sure that the patient is receiving multidisciplinary care in order to make sure that they're receiving the most comprehensive patient-centered care that they can. And future research should aim to validate these findings within a larger group of patients and investigate whether surgical interventions for spinal abnormalities do influence the long-term dysautonomia outcomes in patients with HEDS.
Thank you, Dr. Riley, for having me here today. I'm Bilal, and I'm talking about my project, which was looking at the prevalence of hematologic conditions in patients with Ehlers-Danlos syndrome and hypermobility spectrum disorder. So to just kick this off, hypermobile patients tend to have a lot of coinciding conditions alongside their hypermobility that can limit their daily activities and cause significant fatigue. Understanding the broad scope of all these clinical conditions is important to fully treating the patient and making sure that we individualize these treatments to best serve the needs of said patients. What we note specifically is that we found that there's increased bleeding and bruising in patients that have hypermobility, and as such, it'd be necessary to look next at the prevalence of different hematologic conditions in these populations. So that was our objective. Our goal was to identify and characterize all the different prevalence of hematologic conditions within the populations of EDS and hypermobility spectrum disorder. And our big hypothesis was that patients that are hypermobile will have increased prevalence of hematologic conditions compared to age and sex matched controls that don't have hypermobility. When we think about hematologic conditions, common symptoms include fatigue and difficulty with the activities of daily life. So this is something we want to assess in these patients. So we assessed these in 2 different cohorts. One was at the Long Island Heart Rhythm Center, and we labeled this hypermobile cohort HEART. And also we looked at the EDS and Hypermobility Spectrum Treatment Center, which we labeled as the mobile cohort. And we identified patients based off of if they have hypermobile EDS, classical EDS, or hypermobility spectrum disorder. We utilized ICD-10 codes to identify diagnoses of hematologic conditions, and we compared these to non-hypermobile age and sex match controls. So just to give a couple of examples, we looked at hematologic conditions, including anemia, vitamin B12 deficiency, coagulopathy, and thrombocytopenia, among several others. And what we did was we compared the prevalence of these hematologic conditions between patients that have hypermobility and those that do not. And we set a p-value of less than 0.05 as significant. So what did we find? So our initial cohort in the heart cohort was 164 hypermobile patients, while there was 107 patients in the mobile cohort. We compared those with an equal amount of age and sex match controls from the Long Island Heart Rhythm Center. First, we wanted to make sure that there was no difference between the Ehlers-Danlos patients and the hypermobile spectrum disorder patients. And what we see is that there's no statistically significant difference in the incidence of hematologic conditions in patients that are hypermobile versus those that have EDS. Next, we wanted to look in the heart cohort specifically at the hematologic incidence, and what we find is that there's a 37% incidence of hematologic abnormalities in the heart cohort compared to only 7% in matched controls. We found a similarly significant value with the mobile cohort, where we found 47% of patients had hematologic conditions compared to only 6% of matched controls. By far and away, the most common hematologic condition was iron deficiency anemia, followed distantly by B12 deficiency, coagulopathy, and thrombocytopenia. We defined iron deficiency anemia classically as a hemoglobin less than 12 in women and less than 13 in men, together with a ferritin less than 30 nanograms per milliliter. When we looked at the prevalence of iron deficiency anemia, it was significantly higher in both the heart and mobile cohorts compared to age and sex match controls. And when we looked at the associations between iron deficiency anemia and several different possible contributing factors, such as BMI, gastrointestinal dysfunction, autoimmune conditions, and mast cell activation syndrome, the only associated condition that had a significant relation with iron deficiency anemia was a lower BMI. So the lower BMI was noted in both cohorts, and so we could possibly make a conclusion then that this has a relationship with the iron deficiency anemia being so prevalent in the mobile populations, hypermobile populations compared to controls. So what are our conclusions about this? So our results demonstrate that hematologic conditions are in fact a significant comorbidity in this population of hypermobile patients. We definitely need to be assessing all of our hypermobile patients for any underlying hematologic conditions that have not yet been identified and could be contributing to their lifestyle and fatigue symptoms. Iron deficiency anemia was a lot more prevalent in that EDS and HSD population compared to controls, and so this is a specific hematologic condition that we can easily check using iron panels to assess for in any of our hypermobile populations. And specifically, we see that patients with lower BMI tend to have higher rates of iron deficiency anemia compared to hypermobile patients that have a higher BMI. In that rate, we should be definitely assessing any patient that is hypermobile and has low BMI for iron deficiency anemia specifically. Given the potential contribution of iron deficiency to fatigue, orthostatic intolerance, and other issues such as tissue repair, it's very critical that we identify and treat any sort of underlying iron deficiency in these patients. For future studies, we really want to clarify the mechanisms of why this is actually happening, and specifically what the connection between the low BMI and iron deficiency is in this population. We suspect that there might be possible nutritional interventions that might be helpful in this regard, and iron repletion, we want to assess whether iron repletion could actually improve patients' symptoms and quality of life.
Dr. Todd Cohen is a triple-boarded Johns Hopkins, Stanford, and UCSF trained practicing cardiologist, inventor, educator, and serial entrepreneur. Dr. Cohen built and directed two of the busiest EP programs on Long Island at North Shore University Hospital and Winthrop University Hospital.
He is also the founder and director of the Long Island Heart Rhythm Center and chief of cardiology and director of medical device innovation at NYIT. His hospital affiliations include Mercy Medical Center, St. Joseph's Hospital, Good Samaritan Hospital, Mount Sinai Hospital, and Mount Sinai West. As of 2024, Dr. Cohen has secured nearly 40 United States patents for his pioneering inventions in EP, implantable devices, robotics, and other critical areas. Patents for his innovations have been acquired by prominent healthcare technology companies, including Medtronic and Boston Scientific. He is the inventor of Easy Holder, an inexpensive, sterile, disposable device that functions like a surgical assist, and the Easy Off system, which gives all operators the ability to manually terminate ablation procedures of every type. An expert in medical device innovation, Dr. Cohen is also an enthusiastic and dedicated mentor to future physicians who aspire to be medical innovators. Dr. Cohen has authored many publications, including articles featured in the New England Journal of Medicine, the Journal of the American Medical Association, Circulation, and the Journal of the American College of Cardiology. At NYIT's Ehlers-Danlos Syndrome Hypermobility Treatment Center, he has conducted transformative research into the condition, which can be life-threatening if blood vessels or heart tissue are affected. Dr. Cohen has served as principal investigator of numerous studies, including the pacemaker and implantable defibrillator lead survival study, and multi-center trials, including the NRhythm MRI trial. He also serves on the editorial boards of the Journal of Invasive Cardiology and EP Lab Digest. In addition, Dr. Cohen is an advisor to the Heart Rhythm Society. He serves on the advisory board of the Sudden Cardiac Arrest Association, a non-for-profit patient advocacy charity, and serves on the American Board of Internal Medicine Maintenance of Certification Committee as a reviewer. We're thrilled to have Dr. Cohen with us again today.
It is my privilege to participate in this Ehlers-Danlos Symposium. I want to thank Dr. Riley. I am Dr. Todd Cohen. Ehlers-Danlos syndrome is a complicated syndrome that involves the connective tissue. This slide shows a lot of the hypermobility that is seen in these patients, specifically involving almost all of the joints. As it says in this slide, EDS is complicated. And we as cardiologists in my section here at New York Institute of Technology have had the privilege of seeing and providing the cardiac services to those with Ehlers-Danlos. And we've had a number of observations that we've made over the past 8 years. Specifically, we've looked at a number of comorbidities, and one of the most common one that we see has to do with POTS, but we also see that the patients have palpitation and pain, something I call the 3 Ps. But specifically, some of the other comorbidities we see that have an interplay in this is mast cell disorder, things that involve the spinal cord and cervical spine, such as Chiari malformations and tethered cord, and we see GI abnormalities such as gastroparesis. A lot of our patients, or most of our patients, happen to be female, and they tend to be younger to middle-aged, and many of the patients wind up being lightheaded and dizzy, and some even pass out. ECG findings, electrocardiogram, which is a simple test that I perform on all my patients, show that the patients tend to have a faster heart rate than normal, something we call sinus tachycardia, and some of them even have a short PR interval. And there are different types of people and subtypes of Ehlers-Danlos. At the present time, there were 13 different types of Ehlers-Danlos subtypes. The most common is the hypermobile type, but the other types there is a gene for, and you can see them listed on the slide here. In the hypermobile type, we basically rule out the other types and they meet the clinical syndrome of hypermobile EDS. As a cardiologist, we do simple stuff first. Shouldn't be scared to see a cardiologist because we're just going to get a history and physical examination and start with a simple electrocardiogram. And this shows the electrocardiogram being performed on a patient. It is simple, gives us lots of information, and we do it routinely on all of our patients. With people who have Ehlers-Danlos, we do like to get another non-invasive test called an echocardiogram or a sonogram of the heart. And here we get to visualize the chambers of the heart. And specifically, we are looking at the mitral valve, and we're looking for a common condition known as mitral valve prolapse. And we look at the aortic root for enlargement in this patient population. Again, safe, simple, and non-invasive. So what are the findings that we find in some patients that we look for with this condition? Well, first of all, you can see the normal heart on the left of the slide. And then we can see that some of the patients have this condition called MVP or mitral valve prolapse, where the heart actually has some leakiness to it when it prolapses. And we can pick this up sometimes on an examination. I hear a click on the examination in the middle of the cycle, and it has a characteristic sound, and it's often associated with palpitations. We sometimes also can find some enlargement of the aortic root or the aorta, and in a very small number of these patients, they're at risk for having dilation of the aorta and rarely an aortic aneurysm. I mentioned earlier on about the 3 Ps. And for me, they're palpitations, pain, and POTS, postural orthostatic tachycardia syndrome, which is very, very common. So I'm showing you a slide that I created when I was in Milan of the Last Supper. And you can see that some of the people were very hungry, that they felt lightheaded and dizzy, and they were drooping on one side or the other. And so it's very important to eat like they're doing at and don't wait for the Last Supper. You need to make sure you have your nutrition, stay well hydrated, especially if you have a condition such as POTS. So we talked about these 3 Ps. So we'll start with pain. Pain is almost ubiquitous in those people who have Ehlers-Danlos syndrome. And it is seen here, and it's really a source of discomfort for most, if not all, of the patients with Ehlers-Danlos syndrome. Many of the patients are on all kinds of pain medications to help ameliorate their symptoms. And those medications can sometimes exacerbate this condition that you'll hear me talk about called POTS. Many of the patients have rapid racing of their heart, a condition which as a cardiologist we call palpitations. And that could be just due to a normal rhythm and this dysautonomia of POTS, but sometimes they have more serious conditions because being a human, regardless of whether you have POTS or not, you're prone to, during your lifetime, having some sort of heart rhythm abnormality, what we call an arrhythmia. And sometimes it's significant and sometimes it's insignificant. So we look for palpitations in these patients. And how do we evaluate it? Again, my general approach is safe, simple, and non-invasive. And we like to use this monitor that is almost like a piece of tape that we put on the chest bone. It's good for men and women, doesn't affect the breast tissue, goes right down the middle, and there's a button in the middle. You can see the button, and the button is pressed when the patient has symptoms that may correlate to their palpitations or lightheadedness and dizziness or even passing out. So this, the system I tend to prefer is called the Barty system. We put it on the patient. They wear it for 14 days. They don't even have to come back to return it. They stick it in the mail. It is analyzed, and the results are eventually sent to us, and we go over them with the patient. So what is POTS? Well, this is, you see, is AI Weiwei, a famous Chinese artist that I'm very fond of. And these are some of the parts that Weiwei created. But the kind of POTS we're talking about is called postural orthostatic tachycardia syndrome. And it's a form of dysautonomia. It involves the autonomic nervous system, and patients change their position. Typically, they get up and they feel palpitations, and they may sometimes get lightheaded and dizzy, and it rarely even pass out. And we can evaluate this. Again, we like to do it non-invasively. And that's POTS. Sometimes the condition or conditions like POTS, such as vasovagal syncope, can make patients pass out. And here we see a famous painting by Louis Leopold Boilly of somebody drooping, becoming unconscious, and everybody's coming to the rescue. Well, we like to educate our patients on what they need to do. And the main thing is if they're getting lightheaded and feel like passing out, they should lie down and be recumbent. And certainly they need to be well hydrated. In POTS, or being upright, there is a series of nervous systems, specifically the autonomic nervous systems, that work together to keep us erect when we stand up. And we have the sympathetic nervous system on one side, and we have the parasympathetic nervous system on the other side. The sympathetic nervous system is indicated in red. The parasympathetic nervous system is indicated in green. And together they balance one another out. And when they get out of whack, one can become lightheaded and dizzy, and one can pass out. Other components of the nervous system are also shown in this slide, including baroreceptors, the carotid sinus nerve, the vagus nerve, and the adrenal medulla. And they all affect the heart and the circulation. And they, again, are there to make us maintain our blood pressure and function and stay alert. This is the brain-heart interaction that is seen in Ehlers-Danlos syndrome. So how do we investigate this? Well, sometimes we stand people up and we stand them up for 10 minutes and we check their heart rate and blood pressure while standing and erect. We call it a poor man's tilt table test, but a lot of times we do like to send patients for a real tilt table test where they're on the table, they basically do the same thing, and they're just strapped to the tilt table test, and it's recorded, and it's an easy test, a safe test. We tell our patients not to be scared of this test, and it's very useful at finding the true etiology of their syncope, whether it be one of the orthostatic hypotensions or POTS or neurocardiogenic syncope, and those are all different. They have differences in how they are diagnosed, and it's beautiful to see how the heart rate and blood pressure responds over time and correlate that with the patient's symptoms. Again, a simple test, tilt table test. Well, you know that patients with POTS can pass out. We know that people with Ehlers-Danlos can frequently have POTS. And this is Tracy Morgan, and as a comedian who was on Saturday Night Live and is in lots of movies, but he is funny, but Ehlers-Danlos is not funny, and it's no laughing matter. So how do we treat these heart conditions, and specifically POTS? And this is one of my favorite artists, Wayne Thiebaud. Well, art is a great distraction. It's very useful to get people's minds and thoughts off of their own maladies, so to speak. And so being active, we want our patients with Ehlers-Danlos and any heart conditions to be as active and engaged in the community and the wonderful activities in the community. And if you live in Long Island or New York, there's great things to do all around New York City, and Long Island. But getting back to POTS, which is so common, I'm going to focus in on that. And I like to start with, again, simple stuff, mom and pop kind of stuff. We like electrolytes. So we like the patients to not just drink water and stay hydrated with water, but use electrolytes. And I particularly like Gatorade and Powerade. I like chicken soups, things that are salty. I like salt. It sounds awkward because I am a cardiologist, but I prescribe salt specifically if they have a tendency towards POTS or a low blood pressure. We tell them to have salt or to add electrolytes to their water. Liquid IV is another type. Sometimes I also recommend compression stockings. They're sometimes hard to put on, but we try to persevere. And I particularly like thigh-high compression stockings versus knee-high compression stockings. And if you can't tolerate them, sometimes we even use abdominal binding. So as this wonderful patient of ours is recommended, we want you to stay salty. We want you to add electrolytes to your water. We want you to drink those electrolytic solutions and carry them with you all the time. And it's useful sometimes to monitor your blood pressure with a home blood pressure monitor. Medicines. Yes, some patients still, despite these homeopathic measures, do require medications, but I'm going to tell you that the vast majority of my POTS patients do not, and we can manage them with those homeopathic measures. But there are medications that I put in the armamentarium. I particularly like beta blockers over other medications. I have extensive experience with all the other medications, such as Florinef, Midodrine, and other types of medications. But if we don't need to go the medication route, don't need to go with invasive therapies for this, we prefer not to do that. Sometimes people have palpitations, and it's not positional, like POTS. And these are easy to get in the history. So if somebody's lying supine, or they're not changing position and they feel their heart start racing out of the blue, we often will pick up a less frequent problem, such as supraventricular tachycardia or a rapid rhythm of the heart that is caused by an extra connection in the heart. And that's nice for us to find because these conditions are easily treatable with a procedure that I've done almost my entire life called cardiac catheter ablation. And in cardiac catheter ablation, what we do, the patient is nice and comfortable, sedate on a table, in a safe room, in a monitor room with an anesthesiologist, and wires are placed inside the heart, and we map out the wiring system of the heart, we map out the rhythm, we induce the rapid rhythm, we find out where it's coming from, why it is coming that way, and we get rid of the problem by ablating the tissue and getting it to kind of melt away and disappear so we can cure them of this rapid rhythm. And how do we do this? And what do we do? As a cardiologist, I'm really part of a team, a wonderful team, Dr. Riley's team. Dr. Riley is the director of the EDS Center here at NYIT, and it is a center of excellence. And she's created a multidisciplinary team that I'm proud to be a part of. And she has pain management experts, orthopedic experts, neurology experts, psychosocial experts, sports medicine experts. And we are fortunate to provide the cardiac arm of that therapy. So I just want you to remember that I'm most proud to be a part of Dr. Riley's team, and that there is no I in team. So there is me in team. So it's something I enjoy, and I'm really, really honored to be a part of this team. And here she is, our fearless leader, Dr. Riley. We have the best EDS program in the country. We have very helpful specialists who are really privileged to take care and help patients with EDS. And Dr. Riley always takes EDS to a new level. Well, thank you very, very much.
Dr. Philip Noto is a 2010 graduate of NYIT Com. He completed an internal medicine internship at New York Presbyterian in Queens, a residency in physical medicine and rehabilitation at Temple University in Philadelphia, and a fellowship in interventional spine and pain medicine at JFK Medical Center in Edison, New Jersey. He holds dual board certifications in physical medicine and rehabilitation and pain medicine. Before joining the faculty at NYIT Com, Dr. Noto held a hospital appointment at Moss Rehab, a world-renowned rehabilitation hospital and part of the Albert Einstein Healthcare Network in Philadelphia, as well as an academic appointment at the Thomas Jefferson University School of Medicine. His role was primarily focused in an outpatient pain practice, where patients typically presented with chronic musculoskeletal and neurologic pain disorders. He also frequently consulted on post-cancer pain and Ehlers-Danlos syndrome hypermobility-related pain and function. Dr. Noto also served as the director of inpatient rehabilitation units, where he regularly cared for patients with stroke, spinal cord injuries, amputations, and a spectrum of disabling neurologic disorders. Please welcome Dr. Noto.
So today I'm going to talk to you about a topic that my patients often come to me with, and this kind of hybrid neck, upper back, shoulder pain, what they often call coat hanger pain. I'm going to talk a lot about posture because it's key to how these symptoms develop. Posture can be thought of as the way that we arrange our body segments to move around in the environment, and it gives you a sense of stability while you're still moving around, and our posture is very efficient at doing that. What we'll find, though, is that when we start to deviate from the proper posture, we start to lose some of that stability, and in order to hold onto it, we have to make changes that end up costing us, both energetically, which I'm not going to really talk about much, but in terms of pain, which I will definitely talk about. But before I start talking about pain and muscles and things like that, I want to kind of make a segue into a topic that we all kind of understand intuitively. You can tell a lot about stability by just looking at a line. Over here we have a horizontal line, and whenever this is depicted in some kind of a picture, it usually represents the horizon, which is the ground off at the distance, or the floor, which is the ground close up. Think about carrying something really heavy for a long time and finally putting it down. Think about laying flat on the ground. It's a place of rest, right? Things come to stability over here. They're still. Gravity has nothing else to do at this point. Nothing ever falls off of the ground. And so this is kind of a low energy state. Everything in our environment eventually comes to the ground. Nothing really stays off of it for very long. And if it does, it requires a tremendous expenditure of energy. A vertical line is stable too, but it's a little bit different. If the ground was zero energy state, this is a potential energy state, but it is still stable. It's growth, it's structure. Think about a tree, think about a building, or the pillars and columns that hold it up. Think about your own body. We're the only animals that walk around with upright stability all the time, and we do it efficiently, but we can start to lose it if we deviate from the proper alignment. There's nothing stable looking about this. A diagonal line is used to convey activity. This is kinetic energy. Things are moving. Nothing in the environment, unless it has an external support, can stay like this. This is not just metaphor. It can be a line, or it can be an arrangement of structures in alignment. There's no difference. So alignment for our posture means that our head and our skull are over the spinal column, and the spinal column is straight. And when I say straight for the spine, that means that natural S-curve. And the head and the spine are over the pelvis, which sits at the proper angle, which I'll get into. And all of that is over the legs, which are in alignment. Our skeletons evolved to be able to stand upright with minimal to no muscle use at all. And I mean that when we're truly in neutral upright posture with our arms at our side, we don't use any muscles to hold ourselves up. For any physicians or therapists that might be listening, I am going to simplify more complex ideas, but ultimately the takeaway is the same. When you're standing in this neutral upright posture, gravity is kind of averaged into this force that goes down the core of our bodies. And when you look at it from the side, it goes through our major joints, through the craniocervical junction, through the lumbar joints, through the hip, the knee, and the ankle. When a force is going through a joint, and understand that anything with weight is applying a force, when it's going through a joint, like the fulcrum in the middle of a seesaw, it doesn't move the joint at all. I'll come back to that. Now, nobody stands in this perfect upright posture all the time. We kind of move around, and when we do, our joints start to move away from that vertical line of gravity, and that's when gravity starts to bend our joints. And this is where our muscles come in. They hold us, they prevent us from collapsing, and they move us around. And that's normal for brief periods. Now, I'm going to talk a lot about sitting, and everything that I've said about posture up until now applies to the sitting posture. And I'm going to talk about sitting because we do it for so long. Here, the alignment maintains, and from the pelvis up, it should be the same thing. But if you actually watch people sitting out wherever you are, you will find that they rarely sit in good alignment. There's a number of reasons for this, and a lot of them are environmental. If you take notice of a lot of the seats that we have, they're kind of bucket seats, and they encourage your spine to come out of this natural S curvature and take this C conformation. We have super plush sofas and chairs that we kind of melt into, and the same thing happens. Our spine sort of devolves from that S curve into this kind of primary kyphotic fetal C curve. When we sit like this for a long time, over weeks and months, our muscles start to remodel. When we close into a C, there are certain muscles that get short. And over time, those muscles will remodel and regrow so that they don't have the same length that they used to. Other muscles get pulled long and they become weaker over time. One of the common postural deviations pattern is upper cross syndrome. So this is characterized by a sort of rounded upper back and hunched forward shoulders and a head that's carried forward. So on the left over here, you have the proper upright posture. And on the right, you can see that curve of the upper back. You see the shoulders are drifting forward and the head is carried forward instead of sitting on top of the spine where it's supposed to be. So before I said that when a force is going through a joint, it doesn't impart a force, a torque on it. A torque is a rotational force around the joint. Think about trying to pry open the lid of a can with a coin versus a screwdriver. The more distance you have from the joint, the more leverage you have. And at increasing distances from the joint, you can now start to move the joint with greater ease. The same thing is happening with your head. From the spinal column, where the head forms its joint, carried forward, you have this distance, and gravity now starts to apply a torque to those joints. Look at the sitting posture on the left over there. This is a nice upright neutral posture. You can see the S curve of the spine. In the middle, you start to see a breakdown of that S, and there's a gentle C sweep. On the right, it's much more dramatic. Sitting on the floor, especially like that, with your legs in front of you and crossed, is very difficult to maintain an upright posture. But even when you look at people sitting in a chair, they often have this severity of a kyphosis. So these diagrams came from a biomechanics study that looked at these different kinds of sitting postures. On the left, what you see at the pelvis on the bottom is where it contacts the surface where you sit. And we should be sitting on this part of the pelvis called the ischial tuberosity. It's commonly called your sit bones. When you sit on your sit bones, your spine assumes the normal postures, and your head sits plumb on top of them. You see the schematic on the right to it, where the head and the spine are directly lined up. Most people sit the way you see with the pelvis on the right, where it's kind of posteriorly tilted, and you're not really sitting so much on the ischial tuberosities, but you're sitting more on the fleshy part of your buttock above them. When that happens, your lumbar spine reverses its curve, and if you were to follow it up, it traces this C trajectory, culminating with your head, which is angled down. So we talked about already how a mass over a fulcrum doesn't impart a joint. But when it's forward of that base of support, it falls. So normally when this happens, your gaze is directed downward. For short periods, this is not a big deal. We do this when we're holding something and reading, usually our phones. But what happens is that when our head drops like this, our muscles feel a stretch, and reflexively they kick in under tension, trying to hold our head and preventing it from falling further forward. For prolonged periods of time, this starts to become a problem. There's actually a name associated with neck pain and prolonged cell phone use called tech neck. We don't usually keep our gaze directed down, though. Our nervous system kind of impels us to sort of look forward and keep our eyes on the horizon. We look at who we're talking to. We look at the screen in front of us, whatever's happening in front of us. And in order to do that, those muscles have to not just hold the weight of our head, but they have to level up and actually lift it. So they become shorter, and they still stay under tension. The other thing that's happening besides your head and neck is at your trunk. So here on the left, we have upright posture. That yellow overlay is your shoulder blade or your scapula. And normally it sits behind your rib cage, and gravity is pushing everything down, your scapula, your rib cage, and that's fine. That's how we evolved. The fundamental problem with tilting your trunk forward is that you're changing your relationship to gravity. Gravity is always acting downward. But now if you introduce a horizontal component to your body, gravity is not pushing you down anymore. A component of it is pushing you forward, is pushing your head and neck forward, is pushing your upper back forward, is pushing, really it's pulling your shoulder blades forward. And so you have not just that rounded profile of your thoracic spine, but also this horizontal roundness of your shoulders as they come forward. So in this upper cross posturing, some muscles get pulled long. The problem with that is that they exist under tension for prolonged periods of time, which causes pain as blood flow is decreased. They also get weak. A muscle that is longer than it should be doesn't have the same mechanical advantage, so it can't generate as much force with as much ease. Some muscles are shortened, so the muscles in front, your chest muscles, get shortened because your shoulders just naturally fall forward. Now, you don't usually have pain in your chest from upper cross syndrome, but what happens is that after several months, your muscles start to remodel and they just become shorter. So even when you try to correct your posture now and bring your shoulders back, your muscles are fighting you. The muscles in the back of your neck are shorter, but they're actively shorter because they're lifting your head up, so they exist under tension. So we're going to look at a few of the muscles that are involved over here. On the left, you have the trapezius muscle, the upper, middle, and lower fibers. We're going to focus on the upper and middle. On the right, the trapezius is peeled away, and we have several of the other muscles that are involved. One of those muscle groups is the rhomboids. So when these contract, they pull your shoulders back. And you can see how when the shoulders sort of slump forward, it's stretching these muscles, and it's keeping them under tension as they react and try to pull it back. This is the levator scapula. So it's connected to your shoulder blade, so when it comes forward, it is pulling it along. That length makes it weak, but it's also connected to your neck, which is trying to pull it back up. So it's weak, and it's doing the job of holding your head up. This is not going to be a happy muscle. That's splenius capitis and cervicus. These extend your head and neck. They're also going to be acting in this position, which they shouldn't be. That small triangle, some of the deeper neck muscles, we don't need to get into the names of all of them, but there are other muscles that are holding your head and neck up. But one of the major players in this syndrome is the upper and middle trapezius. So you see that it connects to the base of your skull, all the way down your spine, and off to the side it connects to your scapula. So when your shoulders come forward, it is pulling those fibers long, it's putting it at a mechanical disadvantage, and it's holding your head up at the same time. Not meant to do that. To make sure I'm getting this point across, when I say that these muscles are not meant to hold the weight of your head, your neck, and your trunk up, they are meant to hold it up for brief periods as they're moving you, but they're not meant to sustain the weight of your body parts for prolonged periods of time. That job is for skeletal alignment. So In addition to the sort of exhausted, fatigue-based pain that these muscles are going to start to generate, they can also develop trigger points. Before I kind of leave that sort of fatigue-based pain, I want to put a picture in your head. Imagine taking a light weight, 3 pounds, no more, and carrying it in your hand with your elbow bent, and do that for about 3 or 4 hours. Then put it down, and then do it for another 2 or 3 hours. And then do that every day for a few weeks, or a few months, or a few years. And you can start to get an idea of what your biceps might feel like and what these other muscles are going through when we're putting them in these arrangements. But on top of that, some of these muscles can also form trigger points. So trigger points are like these little contraction knots, not of the entire muscle, but just of a few fibers. And they get caught in these contractions and they have a difficult time letting go. So the two conditions that give rise to trigger points are muscles that are weak and muscles that are overloaded or being asked to do more than they're meant to do. So any of these muscles holding up the weight of your head are under overload. And for hypermobility and EDS specifically, patients have weaker muscles than the general population, and that's well established by research. So we'll look at two muscles, or two parts of the main muscle that we're considering, the upper and middle trapezius fibers. So when a trigger point forms, it's exquisitely painful, and if you press on it, it radiates pain in a characteristic pattern dependent on which muscle is involved. Now they kind of go dormant after a while, but even when they're dormant, they can cause pain, especially when you're using the muscle a lot or when you try to stretch it. So in the middle trapezius, you can see this trigger point over there, and that zone of red is kind of the referral pattern. Upper trapezius is very common for trigger points to develop, and so there's 1 or 2 of them there. And the referral pattern you can see is kind of trickling down to the shoulder, and it's also riding up the back of the neck. When it gets to the base of the skull, it kind of picks up intensity, but it doesn't stop there. So this is the side of the head and neck. And for reference, there's that trigger point again. So the referral pattern is going up the back of the neck, it picks up intensity at the base of the skull, and then it kind of trickles around the side of the head, and it gets more intense again around the eye. Sometimes it can kind of refer pain to the jaw, but usually when patients talk about this pain, they talk about a headache that's at the back of their head, at the base of their skull, and around their eye, and it's usually in the context of this kind of neck pain. There are other muscles that can present with a similar pattern, but upper trapezius is a very common one. So when you look at the muscles that are involved in this pattern and their arrangement, it's little wonder that they call it a coat hanger pain. From the base of your skull, down your neck, out to your shoulders, it forms this kind of triangle pattern. But this isn't set in stone. This kind of pain is usually coming from muscular sources, so it's plastic pain. You can correct this through physical therapy, through doing things like stretching those short muscles consistently over time so they kind of remodel with a greater length, strengthening those overstretched and weaker muscles so they have more tone at rest, and then mindfully watching your posture and how you hold yourself in between that so you're not fighting the effort that you're making in physical therapy with the other hours in the day. Ultimately, over months, this will correct a lot of these symptoms. So I have one more slide over here. This is kind of a famous plate from probably the first anatomy text that was ever published in the 1500s by Andreas Vesalius. I find it very telling that in this kind of whimsical situation, the skeleton is propping his or her head up with the hand. And we do this all the time without realizing what we're doing. But what are we doing? We're giving a break to those muscles in the back of our head and neck. And I think it's instructive that though Vesalius probably was not thinking about biomechanics in this way, did not depict it like this, which I erased just to make the point. So I hope you got something out of this lecture. These are not really references per se. A lot of what I was talking about is just common knowledge in circles of physical medicine and rehab, sports and pain medicine. But two concepts I want to point out. The upper cross syndrome comes from Vladimir Janda, and the trigger points come from Travell and Simmons. Thank you very much.